Okay, so I think we will start. Maybe a few other people will join later on. So today for the colloquium, so I'm sorry because Stephanie could not make it at the moment, neither Anita as well. So I will present Xiaoyi on their behalf. So Xiaoyi did her PhD with Bernard Chalmont at Institut Pasteur, and she has recently joined the lab of Anita Burguin at the Institut Imagine. So a lab dedicated to the study of rare diseases and the genetic basis of these diseases. And so we are happy to have Xiaoyi with us, and she will talk about the patient phenotypic similarity for diagnosis of rare diseases. So thank you, Xiaoyi, and the floor is yours.
Thank you all. So I'm very happy to be able to be here to present to you our work on patient similarity for diagnosis of rare diseases, and also some related ongoing exploratory work. First of all, here are some rare disease facts. So today, over 7,000 rare diseases exist. 80% of them are genetic diseases. And rare diseases affect globally over 400 million people. Half of them are children. Most of the rare diseases don't have yet a treatment. A considerable proportion of rare diseases have a very bad survival. As we can see here, 3 children of 10 with rare diseases won't live to see their 5th birthday. The average time to get an accurate rare diagnosis is 6 to 8 years. The diagnosis is very challenging for multiple reasons. Most clinicians have limited knowledge about this huge number of diseases. About 40% of the general practitioners and 20% of specialized doctors do not have time to work on this diagnosis. Rare patients with non-specific symptoms and other coexisting conditions may lead to the lack of suspicion. Regarding the disease themselves, many rare diseases share overlapping spectrum of symptoms, and our knowledge on many rare diseases are very limited, and new discoveries are constantly being made. Given all this difficulty, many diagnosis support systems were developed with different objectives. For example, they can be more widespread, more accurate, more effective, less expensive, less time-consuming, and so on. Depending on the use scenario, we can distinguish 2 different categories of systems. The first one is patient-centered, which means that a clinician may use this kind of system when facing a new patient. So the clinician have all this information about the patient on desk, and will use the system to suggest a possible diagnosis. The aim here is to reduce miss rate, and the false alarm in this situation is not that important. And the second category is disease-centered, which means that we have a disease of interest. This can be a new research project, new clinical trial. We want to recruit more patients and so on. So in this case, the input is routine care data, where the patient information can be less precise and less comprehensive. And the aim here is to maximize the hit. Our work was performed under the Siligo project with a focus on patients suffering from ciliopathy, a group of rare monogenic disorder caused by ciliary dysfunction, affecting various organ systems, mainly the kidney, the eyes, the brain, the liver, and bone. Today, more than 118 genes have been implicated in more than 50 ciliopathy disorders. This double ring chart showed the relative fraction of ciliopathy-related syndromes and the causative genes. So we can see that different genes can lead to the same disease, and conversely, the same gene can result in different diseases. So this phenotypic and genetic heterogeneity makes the PRAIRIE diagnosis very difficult. And our knowledge about ciliopathy is far from complete, despite that already many genes, many diseases have been found. as new phenotypes are still being described. Also, new genes are being noticed to have an impact on the cellular function. As a consequence, many patients are diagnosed when they have already end-stage kidney disease. Then the only available standard of care is based on dialysis and transplantation. A recent study found up to 0.9% of end-stage kidney disease are due to called carrying NPHP1 deletion, which implies a significant underdiagnosis of ciliobody. So in the context of CILIGO project, as data sources, we have on one hand, the clinical data warehouse of the Necker Children's Hospital, which is a national reference center for rare diseases, containing EHR data from more than 800,000 patients. And on the other hand, the research data repository of the Imagine Institute, containing structured data from more than 1,800 ciliobody patients. Our objective here is to screen patients in the clinical data warehouse to identify potential undiagnosed patients. This is very important, not only because of the underdiagnosis issue of ciliobody, as we said just now, but also because the first potential treatment option has been identified very recently in our project. So the identification of undiagnosed patients will enable them benefit from genetic testing, appropriate follow-up, and also the new treatment. The main challenges include, firstly, the small number of diagnosed cases. In our situation, we have a total of about 200 patients followed at Necker Hospital, but these 200 patients present more than 20 subtypes of ciliobody. It is very heterogeneous. As shown here, many clusters contain patients with different genes from different modules. Conversely, the right panel here shows for each module, I mean the module of genes, the proportion of patients presenting some selected major phenotype, many organ involvement. For example, here the transition zone GBTS module formed a relatively homogeneous group with 80% of patients have eye involvement, 60% patients have central nervous system effect, but it's not the case for some other modules, for example, here. This high heterogeneity can be explained by the complex structure of cilium. So anyway, all I want to say here is that every case counts. In contrast to the small number of cases, the number of controls to be screened is huge, bringing the imbalance issue. There are some more challenges that are related to the nature of the unstructured electronic health record data. The high dimensionality, the dependence and the relativeness between phenotypes, and also the different level of relevance of phenotypes. Given all these challenges, here is the idea. For each patient cases or controls, we firstly apply a natural language processing module to extract automatically phenotypes from EHR. Then each patient is represented by a list of phenotypes. We then compute similarity between diagnosed index patient and all other patients in the clinical data warehouse. Then with the ranking model, we expect to finally enrich the number of true ciliobody cases among the top ranked similar patients. The baseline method considered just a cosine type similarity between two patients. The performance of identifying ciliobody cases among controls was moderate. However, we obtained a very interesting result on ciliobody subtyping using phenotypic similarity. Some gene groups showed high similarity with each other, and they were somehow co-localized in the same or closed module of cilium, which support a new classification of ciliopathy based on the gene modules. To improve the model, the similarity matrix should take into account, as we said already, dependence between phenotypes and also the relevance of each phenotype to each patient. For the dependence issue, we consider the medical concept embedding, which is based on a UMLS phenotype extraction. The embedding encodes the meanings of each concept, so it will allow us to measure the concept similarity. More precisely, for each concept of the indexed patient, we can look for the best match concept of the other patient, which is the most similar one. Here showed how it works with an example. For each UMLS concept, we look for all its French labels. All labels were tokenized, then the token embedding were averaged to obtain the label embedding, and the label embedding were averaged into the final concept embedding. With this simple clustering of concepts extracted from our ciliopathy cohort, we showed the ability to group concepts with similar meanings closer in the 2D vector space. When aggregating concept similarity into patient similarity, we considered the adjusted aggregation to address the relevance issue. So each concept was associated with a weight reflecting the relevance. The idea is that some frequent but less important concepts like fever, fatigue should be aggregated with a lower weight, while the relevance and specific concepts should be associated with a higher weight. Combining with the ranking model based on the average similarity to all diagnosed index patients, we did the first feasibility study using a small data set of only 80 cases and 200 controls. Our developed method provided a better performance than the baseline model, which didn't take into account the dependence and relevance issue. This result was published last year in Medical Informatics Europe. Then the next step is we further exploit this approach, firstly by comparing two other existing embeddings, namely CUI2VEC and HPO2VEC, developed by researchers from Harvard and the Mayo Clinic respectively. Both were learned from a huge amount of English medical data sources. So CUI2VEC is a pre-trained embedding based on word2VEC, where a neural network with a single hidden layer was trained to predict a target word based on its context, neighboring words. Our embedding is based on a skip gram fast test model. The main difference is that it is on a subword level, as we can see here. So subword is each time n letters. Briefly. And the advantage is that it allows to compute word representation for words that did not appear in the training data. So in that case, the root word, the pre and the suffixes could all be captured properly, which makes a lot of sense for medical vocabulary. And HPO2VEC is not a word embedding, but it's a node embedding. It contains embeddings of 7,000 terms from human phenotype ontology trained from various biomedical knowledge resources, such as Almina or ANET, providing basically disease phenotype association. So here the HPO graph was enriched by these different medical resources, and node sampling was performed on the enriched graphs based on random walk, and then followed by feature learning over the sample node And finally, the enriched node embedding were generated. Our objective here is to compare our fast test-based embedding trained locally to these two kind of benchmark well-known embeddings. And our result shows that using less than 1/10 of learning sources, our language and center-specific embedding provided comparable or even better performances. Secondly, we proposed different ranking models and evaluated them. As mentioned already, the first idea is to consider the average similarity to all diagnosed cases, but it's not appropriate because of the high heterogeneity of ciliobodies. So then we consider to use the max similarity, but it may bring high uncertainty because of the noise of EHR data. So we consider the max 5 average similarity for ranking, which share the idea with K nearest neighbor classification, where the neighbors are only searched within the set of cases. And average similarity to searched neighbors was used for ranking. We also considered the average similarity to each subtype and used finally the smallest rank obtained from all subtypes average for the final ranking. We showed here the distribution of the ranks of diagnosed ciliobody patients obtained from these 4 different ranking models, and the partial raw curves. The ranking model using the best subtype average showed the best performance, as it has taken into account the heterogeneity of ciliobody subtypes. Thirdly, we evaluated the final model using 2 data sets containing about 10,000 and 60,000 controls. The difference between these 2 controls data is that the first one contains only active patients with the last records after January 1st, 2017, and the second one was built without this restriction of the date of the latest follow-up. So it includes all the inactive patient as well. The imbalance issue is very important, as the absolute value of the evaluation matrix, such as the precision, may be in this situation meaningless, as the imbalanced case control ratio may inflate the type 1 error. Here we show a toy example. One algorithm with 5% of false discovery rate may reach 95% of precision at 100 in a data set of 100 cases and 100 control. So with 1-to-1 case control ratio, but it decreases to 80%, 50% have 10 times the controls. If we continue increase the number of control to a scenario of 1-to-100 case control ratio, the precision at 100 may fall to nearly 0. So we should remind that in a real life application, the rare disease is by definition a disease with a prevalence less than 1 to 2,000. Therefore, we use these 2 control sets and compare the minimum number of patients that would need to be screened to detect 50, 30, and 20 true positive cases with our model and with a random model. We showed here, for example, a 30-fold and 35-fold improvement in the enrichment of ciliobody patients among the 20 top ranked patients. So we can see that the enrichment factor is not constant, implying the effectiveness of our method in a large-scale, extremely unbalanced scenario. Finally, we performed the detailed clinical evaluation of the top similar control. More precisely, we went through the final ranking of patients from the most to least similar to have a ciliopathy, and reviewed with the ciliopathy experts the EHR of the 21st MET controls. If we take a broader definition of ciliopathy by including all patients confirmed or suspected to have a mutation related with the cellular function, and confirmed or suspected cases to have a differential diagnosis, we reached 81% of success. This makes many sense as it's a phenotype-based screening approach using only EHR data. As a conclusion of this section, we use comprehensive phenotyping from EHR data. Unlike some research, some studies used only a limited set of features presented in the EHR, like the ICD codes or some disease-specific phenotypes. We consider medical concept embedding. There exists, of course, another idea to capture the dependence and the relativeness between phenotypes, which is semantic similarity, like Resnick and Linz. We considered all the overlapped and heterogeneous subtypes as a continuum of disorder for the diagnosis of ciliopathy. The imbalanced case control ratio in our evaluation set is more in line with real-life applications. So the next step will be apply our similarity-based screening in other hospitals. Of course, our study have some limitations. Mainly, the first one is that we consider all phenotypes appeared in the EHR of a patient as a bag of phenotypes. We didn't distinguish, consider the longitudinality of phenotypes. And the second issue is that based on our automatic phenotyping module, there are still some missing extraction of phenotypes, some false positive extractions. So the phenotyping quality should be improved. To address the first issue, it comes to us the idea of building a phenotypic risk score and look at its temporal evolution. In this ongoing work, we also explore the feasibility of integrating prior knowledge of the diseases. We consider a phenotypic risk score as a phenotypic similarity between a patient and a disease, where a disease is represented as a list of phenotypes associated to the disease, either via the knowledge base like HBO, or via a minimum data set defined by our experts in the Siligo consortium. For patient, we considered at the time point T, all phenotypes extracted from EHR from time window of 1 month. Then the accumulation of phenotypes appeared till this time point T was used to represent the patient. This 1 month time window has a real impact as it can avoid this kind of a pseudo-sudden progression of a disease. Once we have the disease representation and the patient representation, the similarity between patient and the disease can be modeled using embedding as we presented just now, or using semantic similarity. Here we explored this second idea by using the ontological semantic similarity. So there are two commonly used information content-based similarities, as we said quickly just now, Resnick similarity and link similarity. Both were derived by the relative position of two concepts in the hierarchy on the ontology. Still with an example of a simplified part of the HPO graph, we would like to compute the similarity between, for example, macro and micro Scobie hematuria. So the key is to calculate, to find the lowest common ancestor of these two nodes from HPO graph. And the Resnick similarity is directly the information content of this lowest common ancestor. And the link similarity is just further normalized by their both information content. So finally, we can have, in this example, a similarity of 0.82 between this micro and micro Scobie hematuria. So now we can compute the phenotypic risk score for each patient at each visit, as we have already shown with a few 5 patients as example. Here is a global picture for all our celiac patients with different subtypes, I mean different diagnoses and different gene modules. Precisely each block present diagnosis. For example, here the nephronophthisis disease, here the Jeune syndrome, senior Loken syndrome, and so on. So what we would like to do is to detect different evolution patterns as shown for this example. For example, here we have a late onset with a slow progression pattern, and here we have some kind of faster progression early onset pattern. So we considered several classic fitting models and choose the ones that minimize the overall root mean squared error. Then we will use the fitting parameters to perform a clustering. Here we showed some first result using different fitting models. And again, the fitting models for these 5 example patients. Different index were considered to determine the best number of clusters. Because of the small number of cases, many of these index very small number of clusters, like 2 or 3. But as we mentioned, considering the high heterogeneity of our cases, we decided to use firstly a relatively larger number of clusters, like 12, to see how it will look like. So here is some first results. We can observe that, for example, in this cluster 7, a kind of early onset cluster composed of patients having mutations in genes from IFTD and IFTA modules. And also here some kind of late onset clusters with moderate progression, mainly composed of patients having mutations in genes from this transition zone NPH module. All this are concordant with expert knowledge. But we still need some tricks to quantify the clustering performance. We can, of course, use the available labels such as the diagnosis or genes, modules. As mentioned already, considering giving the high heterogeneity and the phenotypic genetic overlapping of ciliopathy, this is not a good choice. So we are now working with the experts on the ground truth labeling, which is based on the age of concept, the severity, the prognostic, and so on. Then this will allow us to better assess the performance of clustering. So that is where we are now for this part. Another issue that we mentioned earlier is the phenotyping quality. As the quality of the automatic extraction of phenotype from EHR is essential for everything. It's input for diagnosis, subtyping, for all kinds of predictive models that we considered. To give a concrete idea on the high throughput phenotyping, for a small data set of 10,000 patients, 8,000 distinct phenotypes were automatically extracted based on a dictionary-based method. Despite that, the metadata that we used, the UMLS integrated over 2 million of names for more than 900,000 of concepts from more than 60 vocabularies. The enrichment is still required, which brings the need of considering deep learning named entity recognition models. This work was actually motivated by our findings in previous work. We find that there are a small group of patients, mainly with Chen syndrome, were very often misclassified. And when we checked their profile, their EHR data, we found that most of the patients with Chen syndrome are very poorly phenotyped. That's because Chen syndrome is characterized by skeletal abnormalities with kind of small, narrow, or short bones of arms, legs, fingers, the fifth finger, and so on. So there are so many small details and so many different expressions used by clinicians to describe the patient conditions in the clinical notes. And many of these expressions were missing in the French version of UMLS. So the idea here is to use bidirection gated recurrent unit conditional random field to enrich the UMLS extraction. So we proposed a hybrid pipeline, which mixed the deep learning type extraction and the dictionary-based extraction. So here shows some results. With the standard UMS, we detected only like 600 distinct terms, but with the deep learning method, we detect 1,000 additional distinct terms. Then with the expert review step, we were able to map these newly detected terms to 119 skeletal abnormalities, including some key phenotypes to characterize Chen syndrome. And then we use this enriched, validated a list of enriched UMS dictionary to perform phenotype extraction on the test set. So the result is that we were able to detect as many as 2 times the phenotypes, and we increase the number of detection by 2.5-fold. Here showed some top detected skeletal abnormalities. So with the expert, we can see that many of them, are very relevant to characterize the Jeune syndrome. So that's basically all of my talk. Some highlights is that we really work from the very beginning, the unstructured routine care data, the EHR, to the diagnosis of patient or the disease classification to the very end of clinical application. And we work closely with the geneticist and the clinician to respond to real needs. And all the models we developed in the context of SILIGO project can be, of course, applied to other rare diseases. That's all. Thank you.
Thank you very much for your talk, Xiaoyi. So we have time for questions. So if there is anyone in the audience who would like to ask a question, please unmute yourself.
Yes, I do have questions.
Yes,
and congratulations, it was very nice, very broad, and I like the fact that you work on different facets of the same problem. So very, very cool. I do have a question, which is more technical on the point, because I'm not sure I fully understood on the temporal data you are using. So to be sure, what is your y-axis there? Like here, for instance, so each line is one patient, or each line is a set of patients?
Each line is one patient, and each dot is one visit of the patient.
Yeah.
And the Y is our defined phenotypic risk score, which is a similarity between the patient and the disease. So,
reference.
for example,
so it was you have a disease. Okay, it's what I missed, because I saw similarity, but I wasn't sure if you computed similarity between patients there.
Yeah. So here, actually, it's just a kind of a framework. Of course, we can use other predictive model to define this phenotypic risk score. We can use different references. We can consider purely patient data-driven model. We can use this prior knowledge, the description of diseases from ontological knowledge base. So it's just depends on which we can. What I would like to say is that we can, of course, use other predictive model to present this phenotypic risk score. But whatever, we will finally have this kind of evolution, which quantify at each visit using the phenotypes appeared until this time point. We have at which level the risk to have this disease.
But so then part of that could be then you try to cluster patients based on their profiles here, and it could be also meaning. So it could be that patients have frequent visits because maybe the doctors think that they need to be followed up more. And so you will have close-ups, and maybe you will have more phenotype, or you will have early onset and rapid increase in the similarity, because it could also be that the doctors are kind of biasing, even if it's not really a bias, because they want to see patients more.
Yes, but the clinicians won't see patient more for no reason.
Yeah.
Actually, here we have exactly the an example of patient. I don't know if you see clearly here. So actually the patient was hospitalized from during this period, and we just measure daily something from the blood. So this new visit won't bring new phenotypes. So we will have this kind of risk score stable, constant during this phases. And then once the patient exhibits some new phenotypes related to the disease, we will have this risk score increase little by little.
And do you think it's more important for two patients, if you want to compare patients, to have the same profile, or is it more the age of onset that will be more relevant for two patients to be very similar, or kind of both?
I would like to say kind of both. So that's why we won't use directly the row curves of the phenotypic risk score, but kind of a smoothed curve because of what you mentioned just now. And of course, the age of onset is very important. It's unlike some disease, all patients have a kind of onset at 60 years old, 70 years old, so we can align kind of the curves. But in our case, we do have some phenotypes. Actually, to enter to a little bit more details, the genes from IFT module will give very often some severe patterns. So patients with mutations in genes from this module have a very often earlier onset, and very often some multiple systemic defects. So it's more severe, and the prognostic is worse than genes from, for example, this module, which gives very often juvenile or late onset patterns. And actually, with our new identified the first in-line treatment option, it's basically for this or this kind of patient, we will be able to give some treatment to this patient.
Okay. And if I can ask another question?
Sure.
For overall, when you deal with EHR data, do you think it would help if you would have for all these patients like a whole genome or whole methylome or something like one omics data, non-treated like raw omics data, and how you could merge that with your EHR, and what is your opinion on that?
Of course, if we have more available data, not only the omic data, but also like biological data, all kind of data can help to improve the precision of the diagnosis. But the thing is that as we focus on the screening of clinical data warehouse to detect undiagnosed patient, the most often.
My question for the screening, like all these patients for the screening in the database, you would also have whole genomes.
No, we won't have the whole genome data for, of course, for all the patients from clinical data warehouse. This is also the true situation that many rare disease patients were delayed diagnosis because of they even don't know that they have a rare disease. So this work is based on the idea to address the underdiagnosis issue of ciliobody. It's the same case for many other complex rare diseases where the human knowledge about the disease is relatively limited. And we know that there exist patients that are not diagnosed diagnosed. And so for this scenario, the only information that we have is the EHR, the routine care data.
No, but if it was possible, like in a world where they would have put omics data for everyone in your database, how would you have used this information? It's more a technical question, like how to combine with NLP or this kind of thing. If you have ideas on that.
So we have also explored a little bit this end, but for a better subtyping objective, we have for some of the patients followed at the Necker Hospital, for example, biological data. So the idea will be compute in addition to the phenotypic similarity, some other like a biological similarity, genetic similarity, and so on. And then we can convert all this information from a unique format of input, like the similarity matrix. And then we can try to aggregate different information to improve the subtyping.
Okay, great. Thank you very much.
You're welcome.
All right. Are there any other questions from the audience? If so, you can unmute yourself and ask the question. Okay, so there is none. So shall we thank you again very much for your interesting presentation, and wish you good luck for your future research. Hope to catch up soon.
Thank you.
Thank you everybody for joining. Bye-bye.
Bye-bye.